And welcome back to the afternoon in the plenary session. We got quite a nice afternoon for you, actually. There are quite a lot of edgy topics coming up here. And the first one is something we get asked all the time. So we always ask, wherever I go, I'm asked, why has GIEQs not got more stuff for on-call GI bleeding? And I always say, we got quite a lot of stuff for on-call GI bleeding. What do you mean? And so either we got a problem with the search and finding it, or we didn't do a dedicated session about it. So this session is entirely dedicated to the people who asked me, the many people who asked me to handle the on-call situation, what you do, in what order you do it, and how you handle that situation, which we're all really familiar with, which is basically how to get a view in that very difficult situation. So those really, I've already said the objectives. They are, when should it be urgent or delayed, stepwise approach to get a view, a structured protocol after a negative first endoscopy with ongoing bleeding, when to involve anesthesia earlier on in massive hematemesis, and the checklists and algorithms that go along with this. A quiz question for you. Which of the following is the best approach to a stomach full of blood during urgent endoscopy? That will be presented during this, and there will be no prizes really for understanding which of those is the correct answer. But anyway, if you get it right, you get 10 GIEQs coins, as long as you're the first one to get it right. Okay, so without much further ado, I would like to welcome Lawrence Suki from Canada to GIEQs, acknowledge the journey he's taken to come here, and thank you very much for being with us, and ask him to give his presentation on, in the middle of the night, when should you scope and when can you sleep?
Thank you, David, and thank you everybody for attending. So we're going to talk about risk stratification scores for upper GI bleeds and develop an en route plan when you're actually coming into the hospital after you've decided to get up and come in. I think we've all done call when we recognize the dangers of sleep deprivation. I think there's a lot of focus of this on our trainees and very little on attendings. I think that's something that we try to avoid and protect ourselves as much as possible, as well as caring for our patients. So not an uncommon phone call is a call. A 45-year-old came in with hematemesis, melena, and I'm saying this a little bit facetiously, but the emergency room doctors would love for you to show up while the patient's being rolled in with the scope at the same time. And there's some work to do before that, of course, and some triaging as well. We're not going to scope every patient who comes in the middle of the night with an upper GI bleed, and we'll get into a little bit of the why of that as well, beyond our own self-protection. An excellent triage score is the Glasgow Blackford Scale. Do I calculate it in my head? No, at least not.